Assalamu alaikum. Before jumping into esophageal pathologies, first I would like to talk about two diseases regarding on salivary gland. This is the picture of sialolithiasis. Sialolithiasis simply means stone in the salivary gland. This is the stone in the salivary gland, and this is known as sialolithiasis. Okay, we know there are three salivary glands in human body. First is parotid gland, one is submandibular gland, and one is sublingual gland. Parotid gland usually lies below the ear, and submandibular gland below the mandible, and sublingual gland is below the tongue. And this single stone, this is the single stone usually most commonly found in here, submandibular gland. It is also known as Wharton duct. Now, presentation. This sialolithiasis presents with peri or preprandial pain and swallowing in the affected gland. Pre and periprandial pain during swallowing in the affected gland. Can you remember a disease where there is postprandial pain? The disease is superior mesenteric artery syndrome. In superior mesenteric artery syndrome, the superior mesenteric artery compresses in between aorta and third part of the duodenum, causing these postprandial pain. And pre and periprandial pain occurs in where? Sialolithiasis. Now, cause. First, it may be due to dehydration, it may be due to trauma, and the treatment is as there is pain, so you can give NSAID, you can do massage of that gland. If there is submandibular gland problem, you can massage those submandibular gland and warm compression. And other thing, you can offer the patient sour candy. Sour candies actually elevate your or promote your salivary flow and thus decrease the symptom. And that's all about sialolithiasis. Now, this is the histological picture of salivary gland tumor, and most commonly we studied in the MBBS that pleomorphic adenoma is the most common salivary gland tumor, and this is the histological picture of pleomorphic adenoma. Most of the salivary gland tumor are benign and commonly affect the parotid gland. Can you remember that a sialolithiasis most common gland where sialolithiasis affects, that is submandibular gland. On the other hand, salivary gland tumor usually affects parotid gland. Nearly half of the salivary gland neoplasm and most sublingual and minor salivary gland tumor are malignant. Presentation is painless mass or swelling, and it presents with painless mass or swelling. And if it involves cranial nerve 7, then you should think that it has already metastasized, that is malignant involvement. That cranial nerve, when there is involvement of cranial nerve 7, it suggests malignant involvement. And the most common is pleomorphic adenoma. Pleomorphic adenoma is a benign mixed tumor. And another thing you have to remember, that pleomorphic adenoma composed of chondromyxoid stroma and epithelium. Chondromyxoid stroma and epithelium. And recurs if incompletely excised or ruptured inappropriately. It may undergo malignant proliferation. So in pleomorphic adenoma, you have to remember the composition, that it is composed of chondromyxoid stroma, and it can recur if it is not excised well, and it has a malignant potential. It may undergo malignant transformation. And second one is mucoepidermoid carcinoma. This is the most common malignant tumor. Mucoepidermoid carcinoma is the most common malignant tumor, and it has mucinous and squamous components. You have to remember the composition, that in mucoepidermoid carcinoma has squamous and mucinous component, and the other high yield is Warthin tumor, also known as papillary cyst adenoma lymphomatosum. Papillary cyst adenoma lymphomatosum. You can remember by this mnemonic that warriors from Germany love smoking. Warriors, that means Warthin tumor from Germany, that means germ cell tumor, Warriors from tumor love smoking, and smoking is the risk factor. So in Warthin tumor, you have to remember that Warthin tumor arises from germ cell, and the most common risk factor is smoking. So that's all about the salivary gland. Now I am going to esophageal pathology. This is the most common bird big picture. In the MBBS level, we actually see this picture plenty of time. Whenever we go through the ENT, this picture is most common, this bird's big appearance. This is found in achalasia cardia. What happens in achalasia cardia? In achalasia cardia, there is failure to relax the lower esophageal sphincter due to loss of what? Myenteric plexus or black plexus, due to loss of postganglion inhibitory neuron, due to loss of myenteric plexus, due to loss of postganglionic inhibitory neurons. And we know that postganglionic inhibitory neurons contain nitric oxide and VIP. Now presentation is this person presents with most common one is dysphagia, progressive dysphagia to solid and then liquid, progressive dysphagia to solids and liquid. And in obstruction there is only solid, but in here there is solid and liquid both, progressive obstruction of solid and liquid, and in obstruction there is solid only. And you can confirm it by doing manometry. If your manometry is esophageal manometry, in esophageal manometry you get high LES, high lower esophageal sphincter, high LES in esophageal manometry, and there is increased risk of esophageal cancer, and there is increased risk of esophageal cancer. And can you say what type of cancer happens in achalasia cardia? In achalasia cardia there is squamous cell carcinoma. All you have to remember that GERD, Barrett, and obesity, smoking. Obesity, this is the three cause where there is adenocarcinoma, and in achalasia there is propensity of having squamous cell carcinoma. And you have to remember this thing mostly, that in manometry finding, in manometry you may get high LES. This is the picture of diffuse esophageal spasm, also known as nutcracker esophagus. Diffuse esophageal spasm, also known as nutcracker esophagus. In here there is normal LES when you do manometry. This is one of the high yield thing you have to remember. In diffuse esophageal sphincter there is normal LES. In here there is impaired neural inhibition, which leads to dysphagia and angina like chest pain. If the patient comes with dysphagia and angina like chest pain, and in barium swallow you get this corkscrew esophagus, then you can say that this is diffuse esophageal spasm. This is corkscrew esophagus. And manometry is a diagnosis where there is normal LES. And I haven't tell the treatment in these two things. I want to say it elaborately, that's why I skipped that. In achalasia cardia, in achalasia cardia, the most common causes, it may be there are some secondary cause of achalasia. In achalasia, the primary cause is failure of the lower esophageal sphincter to relax due to loss of this mesenteric plexus, and there are some other secondary cause of achalasia which is caused by a bug called Trypanosoma cruzi, and Trypanosoma cruzi causes Chagas disease. And now I would like to discuss about the treatment of achalasia cardia. In achalasia cardia there is medical treatment, there is surgical treatment. In medical treatment there is calcium channel blocker, and you can give botulinum toxin. And for surgical purpose you can do Heller's operation, also known as Heller's pyloromyotomy, and you can do pneumatic balloon dilatation. And now in diffuse esophageal spasm, the treatment is, as there is angina like chest pain, so you can give nitrate, you can give calcium channel blocker. So nitrate and calcium channel blocker is the treatment of choice. Now this is the picture of eosinophilic esophagitis. There is esophageal rings with linear furrow. This is the linear furrow, esophageal rings with linear furrow. You have to remember this, that in eosinophilic esophagitis there is esophageal rings with linear furrow. And usually seen in atopic patient. Can you remember the term atopy? In atopy, normally in response to infection there may be production of IgG. In spite of producing IgG, there is abundant amount of production of IgE in some patients, and these patients are called atopic, and this condition is called atopy. And in eosinophilic esophagitis there is food allergens, dysphagia, food impaction, and typically unresponsive to GERD therapy. They are typically unresponsive to GERD therapy. This is the picture of esophageal rupture, esophageal perforation. This is the picture of esophageal perforation. And most commonly due to esophageal instrumentation, and non-iatrogenic causes include spontaneous rupture, foreign body ingestion, trauma, and malignancy. And it may present with pneumomediastinum. This is the picture. This is aortic arch. This is trachea, and in here there is air in the mediastinum. It is called pneumomediastinum, and there may be subcutaneous emphysema, but maybe dissecting here. Subcutaneous emphysema may be due to dissecting here. Signs include crepitus in the neck region or chest wall. Signs include neck and chest wall. And now Bohr-Habb syndrome. In Bohr-Habb syndrome and in Mallory-Weiss tear, what is the difference between Bohr-Habb syndrome and Mallory-Weiss tear? Can you remember Mallory-Weiss syndrome? Mallory-Weiss syndrome. In Bohr-Habb syndrome there is transmural involvement. It is transmural. And in Mallory-Weiss it may be mucosa and submucosal involvement. Mucosa and submucosal involvement. And in Bohr-Habb syndrome there is diffuse esophageal rupture due to violent retching. In Mallory-Weiss syndrome there is longitudinal laceration. There is longitudinal laceration. There is longitudinal laceration in Mallory-Weiss tumor, and it happens due to severe vomiting, not due to violent retching. And the most common cause of Mallory-Weiss tear is alcohol and bulimia. Alcohol and bulimia nervosa is the most common cause of this Mallory-Weiss tear. Now, this is the picture of esophageal varices. This is a varices. In esophageal varices there is dilated submucosal vein. In the lower one-third of the esophagus, secondary to portal hypertension. Lower one-third of the esophagus, secondary to portal hypertension, common in cirrhotics, may be the source of life-threatening hematemesis. And now esophagitis. This is another MRI of esophageal varices. This is the picture of esophagitis. This is due to candida. In esophagitis it may be occurs via candida. In candida there is white pseudomembrane. Look at the white pseudomembrane. And if it is happened by HSV1, there is punched out ulcer. And if it is happened by other cause like CMV, it causes linear ulcer. In CMV infection. You have to remember these three things. In CMV there is linear ulcer, in HSV there is punched out ulcer, and candida there is white pseudomembrane. Can you remember where there is longitudinal laceration? Yes, in Mallory-Weiss there is longitudinal laceration. Can you remember where there is transmural involvement? In Bohr-Habb syndrome there is transmural involvement. Now Palmer-Vinson syndrome, also known as Peterson-Cali syndrome. In Palmer-Vinson syndrome, what happens? You have to remember these three things: that dysphagia, iron deficiency anemia, and esophageal web. Dysphagia, IDA, and esophageal web. And these three things found in Palmer-Vinson syndrome. Schutzki's rings webs. In Schutzki's rings webs, you have to remember the location where it is happened. It generally happens in gastroesophageal junction, GE junction. It usually happens in GE junction, gastroesophageal junction, and it also can present with dysphagia. And other is sclerodermal esophageal dysmotility. In sclerodermal esophageal dysmotility and scleroderma, there is Crest syndrome, that means calcinosis, Raynaud's phenomenon, esophageal dysmotility, syndactyly, and telangiectasia. So esophageal dysmotility usually happens in scleroderma. And in histopathology, there is atrophy and fibrous replacement of the muscularis in the lower esophagus. There is atrophy and fibrous. There is atrophy and fibrous replacement. Atrophy and fibrous replacement of mucosa. Replacement of muscularis in the lower mucosa. Muscularis in lower esophagus. And the last disease is GERD, gastroesophageal reflux disease. In gastroesophageal reflux disease, it also presents with chronic cough, hoarseness, chronic cough, hoarseness. It is associated with asthma, and the and in here the most important thing in here, there is decreased LES, lower esophageal sphincter tone. Can you tell me where there is increased LES? Increased LES found in achalasia. Can you tell me where there is normal LES? In normal LES, they are found in diffuse esophageal spasm. Can you say where there is decreased LES? Yes, it is found in GERD. And that's all about esophageal pathologies. Inshallah, you will be benefited.